Those of you who follow me on Facebook probably know that my wife is a health coach. And for a health coach, what's not to love about a 12-day festival known for quirky beers, sugary concoctions, and deep-fried food on a stick? Nothing. But I'll bet I can get 2 million of my closest friends to agree that one Pronto Pup isn't going to kill me. But when overindulgence leads to heartburn and heat exhaustion, we're there for you with our top-notch event medicine team and the mobile response of St. Paul's bravest. But enough bragging. We talked about event medicine last year during the 2017 Somerset Music Festival. This year, we're going to focus on 3 things that we hope don't involve the Minnesota State Fair: pelvic binders, difficult conversations, and critical incident stress management. So guess what? This is Regions EMS Update. I'm Dr. Peterson, and those are the 3 things you need to know. Gravity, gravity, gravite. No matter how you say it, it doesn't change what it means. What goes up must come down. This is one of the unchangeable laws of physics, which just so happens to provide us with a little bit of job security. Unfortunately, us humans were not designed to celebrate the radical extremes of gravity. We have invented many ways to go up, and even more ways to come down. When the down part doesn't go quite as planned, that's where we come into play as EMS professionals. Last month, we talked about tourniquets and wound packing. Sometimes the injuries aren't quite so obvious. Let's look at another injury that causes disability and death, and the intervention that we can do in the field to stabilize it: the pelvic binder. Here's what you need to know. Humans are capable of sustaining incredible levels of blunt force trauma. When things go bad, there are parts of our body that tend to predictably absorb the majority of the energy. Extremity fractures are painful, but usually survivable. Head trauma is a major source of death and disability, despite our best efforts. We talked about chest trauma recently, and abdominal trauma usually needs a surgeon. So that leaves us with the pelvis.
It's all in hips.
Blunt trauma to the pelvis is bad. For any part of our body that has a bony cage protecting something, there's probably a good reason that something needs protecting. Think about it: the brain, the heart and lungs, and the pelvis. So what's in the pelvis that needs to be protected? Blood vessels. Lots of blood vessels. The average volume of the pelvic cavity is about 1.5 liters. The problem is that once you disrupt the pelvic ring, the volume increases significantly. When other structures are damaged, blood can track into the abdomen, behind the abdomen, and even down into the thighs, which could easily contain 5 liters of blood, otherwise known as your entire blood volume. Even though we can't directly stop the bleeding, if we can stabilize the pelvis and limit the volume, we can theoretically contain the blood loss to no more than about 1.5 liters. Of course, this assumes that other important structures are intact, but that's usually beyond our control in the field. So how do we stabilize the pelvis? We need to understand the common injury patterns. The pelvis is a 3-dimensional structure, so not surprisingly, there are 3 typical patterns we see with blunt trauma. Lateral compression forces, such as a T-bone collision, crush the pelvis from the side. AP, or anterior-posterior compression fractures, are often seen with motorcycle accidents or other direct frontal impacts. This is the classic open-book pelvic fracture that you hear about. Vertical shear injuries are often seen with long falls, where a significant force is transmitted up through a leg to the pelvis. A pelvic binder can be used to stabilize the pelvis and limit the volume available for blood loss. Although they are most helpful with open book fractures, they can be used with any pelvic fracture pattern. The goal is to restore normal anatomy, not to completely compress the pelvis and make the injury worse. The following video will give you some tips on applying a pelvic binder using the correct anatomic landmarks. Check this out.
To stabilize this nasty open book pelvis fracture and reduce hemorrhage, you're going to want to place a pelvic binder. And the most common mistake is to place it too high. So let's review the anatomy. When I stand here next to Mr. Bone Jangles, you can see my iliac crests are all the way up here, and there it is on Skelly. And here's the greater trochanters of my femurs, which you can see on Skellingsworth here, and it goes around the greater trochanters. The greater trochanters, it looks low, but that's where you're gonna go. Now there's many different brands of pelvic binders, which isn't so important, and you can use a sheet in a pinch too. The most important thing is to remember that pelvic binders are just like real estate. It is all about location. And I repeat, it goes around the greater trochanters, not the iliac crests. It gets tightened, but not too tight, and secured. I'm Dr. Jess Mason, and he is orthopedic surgeon, Dr. Stuart Kerr.
If you've been in public safety for any length of time, eventually you're going to have a difficult conversation with someone. Telling someone that their loved one or their child has died is one of the most emotionally challenging things you will do as an EMT or paramedic. Unfortunately, death notifications are only one of several difficult conversations that we have to have from time to time in our role as EMS professionals. Even as an ER physician who does this on a regular basis, this is still a part of my job that I absolutely dread. Our region's EMS team had the opportunity to chat with an EMS professional who has a passion for teaching others how to have these difficult conversations. Hopefully you find this as helpful as we did. Here's what you need to know. So we're here with Alex JABR, who's a paramedic and an educator out in California and has some special interest in teaching paramedics and other EMS professionals on how to have difficult conversations with patients. Death is a reality of our profession, and not just death, but other traumatic situations that we might find ourselves in. So we're very thankful that Alex took some time out of her day to share some of her experience and wisdom with us. So Alex, why don't you introduce yourself? Tell us a little bit about your background and what you do out in California.
My name is Alex. I work for Riverside County Fire Department in the EMS Bureau, so doing training, education, reviewing calls. I also work at Victor Valley College as an adjunct faculty with their paramedic program, EMT program as well. And I've been in this field since I was 18 years old. I did this right out of high school. Ironically, I picked this profession because I didn't want to go to college. And I thought I could get away from it for a while. And it took me about, let's say 14 years before I got my, no, not 14, maybe 12 years before I got my associates, and I didn't really stop after that. I ended up switching my focus from EMS to mental health once I decided to go into my master's program. And the focus that kind of appealed to me most was in grief and bereavement. So we learned a lot about death, grief, how people process death, what makes the grieving process more difficult and whatnot, and as well as like trauma and PTSD and suicide. So those are two of my big focuses right now, and will continue to be so because I'm continuing with my PhD in psychology.
Was there anything specific that got you interested in this specific field of psychology and medicine?
Biggest reason was it was kind of accumulation of events, but honestly, I really disliked my bachelor's degree, and I thought if I'm going to go for my master's, I'm going to pick something interesting. What was something we were lacking? What was something that we lacked every time we put a new academy out into the field? And there's only so much time to go over all the curriculum that's mandated by the state and by the national standard, and there's so much that we overlook. And one of the things was, how do we let people die? We teach our students and our paramedics who are out in the field how to intervene death, but we don't tell them how to support the family once there's nothing more we can do for the patient. And there's been absolutely no training in that, nothing formal anyways. And I saw an opportunity to kind of bridge that gap. So that's what kind of led me to that. I thought, okay, well, how about I just start teaching the stuff I want to teach, the stuff that we're craving for, we want more training in. So that's kind of what drove me where I'm at right now.
So let's go back to some of those difficult conversations. And when you talk about this, when you present on this topic, what are the tips or the things that you like to bring up that might help some of our responders next time they have to deal with this?
Well, one of the things I like to start off with is, our field is not a mathematical equation. We can do every single thing right, and the patient still dies. And I think when we have to have that conversation with a family member, that really is associated with that feeling of failure, whether we realize it's happening or not. And so reminding at not only the student level, but the provider level that's already out there functioning in the field, but telling them that, it's completely okay to have this conversation with the family. It's, this is what you're gonna expect when you have the conversation with the family. Always tell the truth is a big part. Always tell the truth. Be comfortable using the word dead and died. People want to tiptoe around that word when in these situations, and I default to it as well. I'm not saying it's not easy to say your mother is dead, but when you're speaking to someone who is in that state of panic and stress, they're not going to process, they're not going to make it, or they're no longer with us. They're not going to process the euphemisms that we use for death. So telling the truth, being comfortable with those words, understanding that the family's response is not always going to be pleasant. Sometimes they're going to get angry with us, and there's always that fear of, what about our safety? And of course, if the scene is no longer safe, then that trumps everything. But more often than not, we have to remember they're scared. They just received some terrible news, and the way the brain works when they trigger that fight or flight, they're wanting to find someone to blame it. Sometimes that is us. And why wait until minute 17, 18, 19 to start breaking that news? Start at minute 1 and keep them involved in the process and letting them know what's happening. And it actually makes it a little easier on us as well, because we're doing microdoses of this thing. And, I think that all that aside, sometimes saying nothing at all is just as effective. We do not have to fill the space. We do not have to fill the silence with excess words. That's when I tend to shove my foot in my mouth and say something I wasn't supposed to. So, sometimes silence is completely okay. So
what if I find myself in a situation like this and I just don't know what to say? What advice, are there any mental reminders or things that I can use to prompt myself when I just don't know what to say?
I'd say that after the introductions have been made, the rapport has been made, maybe you've respected the silence that has naturally occurred, but now they're asking questions and you don't know how to answer them. I would say one of the best ways to approach that is to ask them what they understand. And this goes back to, especially when dealing with children. So let's say you have to answer to a child about what they understand about their parents' death. And so you start by asking, what do you understand so far? And then you kind of get an idea of where you need to fill the gaps. Because if you're just talking about something they already get, you might lose their focus and train of thought because they've got a million things running through their head. So kind of start by asking questions. You can never go wrong by asking questions to see where they're at versus, and that's what communication is. I think that communication is so much less about what we're saying and more about what we're asking. And so I would say definitely say those things. And then some things not to say are, don't sugarcoat it. Don't say, they're in a better place. Don't say calm down. Do not say calm down, because that's the last thing that'll happen. There's a few other things that aren't coming to mind right now, but those are the basics. Those are the big ones.
Well, Alex, thank you so much for sharing your wisdom and experience with us today, and for taking the time out of your busy schedule, I'm sure, to share some of this with us. If anyone has any desire to learn more about this topic or dig a little bit deeper into this, feel free to reach out to our EMS education department, and we'll be happy to look into this and help you out as much as we can. Thanks for having me. I appreciate it. If you've ever experienced a call that involved a difficult conversation, you probably know that the call, or sometimes the conversation, can stick with you for a while. We've talked about this before. We have to take care of ourselves and look out for each other. One of the ways we do this is by processing the calls while they're still fresh in our minds. Here's what you need to know.
Hi there, my name is Tia RADANT and I'm the manager here at Regions EMS, and I'm also a peer volunteer on the Metro CISM team.
Hi, I'm Jennifer SHEA, Education Supervisor and producer of the monthly update. So Tia, can you tell us what CISM is?
So CISM stands for Critical Incident Stress Management, but it generally encompasses a lot of this peer support that the Metro team provides around emergency services. And so the Metro CISM team includes volunteers who are current members of police, fire, EMS, dispatch from around the Metro area. And we also have statewide teams around Minnesota and into Wisconsin that we will do mutual aid and referrals to. I joined the team about 11 years ago and have been doing debriefings and one-on-one peer support and trainings ever since.
So Tia, what made you decide to be a volunteer?
You know, I think the concept of cumulative stress in EMS is really important, and there are certainly lots of resources out there and people who've spoken on this around the country. For me, it wasn't a single call that really made me decide that I needed support from CISM. I knew that it was a couple of calls together that was really impactful. And I sort of think of a critical incident as, and the process you go through, so you're sort of fuzzy afterwards, maybe you can't sleep, maybe you're on edge, maybe you're sad and just crabby. And you sort of go through this process over a few days where you have to rethink and relive this event and talking through it and having support, whether it's a debriefing or one-on-one peer support, or partnering with one of the mental health professionals that's on our Metro team to really, find the right type of support for you is very helpful. But to me, I think about it as organizing a junk drawer. So everybody has a junk drawer in their house, and everybody knows that it's sort of an uncomfortable situation the day that you realize you have to clean the junk drawer because you just can't handle it anymore. And the only way to clean out a junk drawer is to take the junk drawer and dump it out on the kitchen table and make a much bigger mess. But the process of putting those things back in order doesn't change what was in the drawer. The drawer was still full of the same items, but it's a little bit more organized, and the next time you pass by that drawer in the kitchen, it's not going to bother you quite so much. And for me, that's exactly what critical incident stress and the healing that happens when getting support is really about. You'll never not be a part of the incident that was critical for you. It will be your incident. It's still your call. But rather than having it right here in your face and really traumatic and uncomfortable, there are ways to sort of package it and be able to safely and in a more healthy way put it aside. And so for me, the calls with kids are really hard, and a couple of things that sort of trigger past critical incidents. But because I have that junk drawer organized, I can choose when I want to open it up, and I can choose when I want to think about it, and it gives you a sense of control again.
So you did mention physiological changes soon after an event. Tell me what some of those are.
Sure, there's actually a myriad of chemicals that get dumped into your system in the immediate time after a critical incident. So we all know of the adrenaline rush, but that's not the only one, right? And the three things that we really recommend that providers do and we can do for each other in supporting ourselves is drink water, because you have to flush out those chemicals. Be okay with needing some time and allowing space and time. And then being okay with emotion. And that's really hard for people in emergency response. We're okay with if the public has emotions. We just don't particularly want to have them ourselves. But we have to be okay with the fact that there's this overwhelming physiologic response happening, and everybody will be different.
So asking for help isn't that you're weak?
No, it means that you want to be really good at your job and stay in your job for longer. I really believe that asking for help is a sign that you're committed to a long and healthy career, and you want to get back out there.
Interesting. Now, you've referenced the Metro team. Do they have this in other areas, like Wisconsin?
Absolutely. So there are teams around the state of Minnesota and Wisconsin, and the Metro CISM team certainly has referral processes to be able to connect people with the right team in their area. And also, the Metro team can provide mutual aid to the different teams around Minnesota and Wisconsin. And in fact, the Twin Cities Metro team has provided mutual aid across the country. We responded to 9/11 and to some of the other hurricanes as well.
I was very interesting. Where do I go if I want to find out more, either about the services or how to volunteer?
Yep, absolutely. So the Metro team's website is metrocism.org, and we are dispatched through the West Metro MRCC, which is 612-347-5710. So one of the things you'll find on our website are some great resources, one of which is a story about a firefighter describing cumulative stress, even in the veteran fire service.
We were sitting around the station. It was a Sunday afternoon, playing tiddlywinks or whatever. Probably not that, but I think we were playing cards. And I remember vividly complaining. It was boring. So this is boring. There's nothing going on. I wish it was a fire. And then the bell tipped and off we went. There was a fire across the street from the Admiral Street Fire Station, right across the street. It took us about 5 minutes to get there. We were in a different part of the town. And there were 2 kids in the rear bedroom. Search went on and they took the kids out and they were dead. 2-year-old and a 1.5-year-old. No, it was 1.5 and 3-year-old. And I was on the rescue that day, detailed. I was normally on the fire engine, but for some reason I've been detailed to rescue. So the fireman brought the one baby to me and just handed it to me. And then the body was so hot, my gloves actually melted onto his skin. And then they brought the little girl out, and I had them both. And I brought them over to the rescue. And I was a fireman at the time. I wasn't even in EMS. I was an EMT basic. So I did what EMT basics do. I had both of them on the stretcher, doing compressions on one and bagging the girl. And anyways, I thought it was pretty bad, but I handled it, so I thought, very well. Brought them to the hospital and tried, but they died. Then we have this thing called a critical incident stress debriefing. About a week later, and there was a veteran firefighter there, a guy named Billy, and we were talking about it, and it's supposed to help, but being an arrogant young man, I was kind of didn't need this, and I was just kind of going along for the ride. And Billy broke down. I just couldn't understand it. I truly couldn't understand why, because that's what we do, you know. The kids died, and it didn't bother me, so I thought, but I talked to Billy some years later, and he remembered that incident debriefing, and he remembered looking at me and saying, yeah, he's going to be in my shoes someday. And sure enough, I was. It just culminates. That call 24 years later, it's vivid as yesterday. It truly is. It's and it did. It stuck with me, even though I didn't think it would. And all the other calls that went after it, they just add up. They really do. And it's we deal with it. We go on, but it changes you. It changes you a lot. And plus age, and I don't think we're anything far different from people aging and experiencing life. It's just a little more colorful at times, I think.
Hey, thanks for hanging out with us this month. I know we don't always talk about gory, exciting topics, but I hope you sense our passion for professionalism and making sure that you are mentally, physically, and emotionally ready for whatever the next call might bring. And if any of these videos are helpful to you in any way, tell a friend. Follow us on Facebook, YouTube, and Twitter, and send us a quick email to let us know what topics you would like to see on an upcoming episode. At Regions EMS, our door and our email inbox is always open. Remember that we don't operate an ambulance service, so our entire focus is making sure that you are successful in providing high-quality emergency care to your communities. So with that goal in mind, from all of us at Regions EMS, I'm Dr. Peterson. Be smart, be safe, and be professional. We'll see you next month.